Thank you very much for this opportunity to really represent our work in Ain Shams University about salvaging of thrombosed vascular access. I believe many of our colleagues have actually seen part of this presentation before, but actually we are very enthusiastic about this topic, which I think that it was left for decades without clear boundaries about what to do. I just will go through the Kaduki guidelines first, and as we know, the optimum. Sorry, I cannot see the slides here on the computer. The slides مش طالعة على الكمبيوتر عندي. ما تتحركش يا أستاذ، ما تتحركش. So the optimum hemodialysis access choice is a mature arteriovenous fistula followed by the graft. And maintaining patency and function of an arteriovenous access is a real challenge. Stenosis is the most common complication following an AV access, and venous stenosis with consequent thrombosis is often the result of new intimal hyperplasia and leads to several serious sequelae in both AV fistula and grafts. The complete AV access thrombosis represents a terminal event for the failing AV access and accounts for 65 to 85% of all AV access abandonments. Although the contributory cause of the terminal thrombotic event is obvious in most of cases, patients can present with de novo thrombosis without any clear failure mechanism from before. And the Kaduki guidelines actually mentioned very clearly that failing or failed AV access, there is no role for anticoagulation, and we still see many nephrology doctors and vascular surgeons are treating these patients with failing or failed grafts with anticoagulation. And the Kaduki guidelines as well didn't recommend to abort the use of the fistula or the graft if it was thrombosed recently and just go for a de novo access, which we still do in many units. The immediate success to provide at least one effective dialysis session after a procedure of removal of the thrombosis and restoration of the function could be achieved in 80 to 95% in thrombosed access, although the long-term patency rate are quite poor. And there are many techniques described to salvage a thrombosed AV access. These techniques are either open endovascular or hybrid. Recent studies didn't really recommend a single technique that has proved superiority over others. For any technique to be successful, it should clear the thrombus load in the AV axis, partially or completely, and to treat the underlying disease if a stenosis is present, which is more than 80% of cases. The open surgical techniques include open thrombectomy, surgical correction of the stenosed part of the AV axis at anastomosis, or the vein graft itself using patchplasty, jumping graft, or resection of the disease segment. And the endovascular management include endovascular mechanical thrombectomy, continuous thrombolysis, pulse spray thrombolysis, combined pharmacomechanical thrombectomy with completion angiogram and angioplasty. The hybrid techniques include open thrombectomy followed by angiogram and angioplasty to achieve similar results. So why should we think about salvaging a fistula rather than doing a new one? With the aging population and lacking national transplant program in Egypt, we might need to reconsider every functioning AV axis as a valuable axis. So our practice actually, we started doing continuous thrombolysis infusion for thrombosed AV grafts, and we have published our results, which actually was quite a good outcome, but the problem, it comes with a high cost, prolonged hospital stay, and bleeding risks. Then we have adopted the technique of pulse thrombolysis followed by angioplasty in the same session, and we compared the different doses of RTPA 6 versus 10 milli pulse thrombolysis with similar results, but unfortunately because of financial constraints we got limited to use the angioplasty equipment in the emergency cases unless if it's life-saving or limb-saving. So we have started to adopt a new technique to do a thrombolysis first, followed by surgical thrombectomy and angiogram, and just to restore the function of the fistula, and then defer the patient to another procedure to have angioplasty later on as an elective procedure. We have included patients who had recently thrombosed AV access less than 14 days, and all of them were already mature and used for dialysis for more than a month, and the patient age was between 18 to 75. We have excluded patients with absolute contraindication for thrombolysis and or anticoagulation, patients with symptoms or signs of AV access infection, and patients who didn't accept the risk of bleeding and failure of restoration of the access function. So how do we do it? We go first with ultrasound guided puncture. Usually, if the patient had an early thrombosis, there will be a small segment that's still pulsating at the beginning of the vein, just juxta-anastomotic, and then it will be followed by the thrombus in the vein. And usually, we go with the cannula, a 16 or more gauge needle inside this to inject 1 ml of RTPA with a rate of 1 ml per minute under ultrasound guidance. And we start injecting saline first to be sure that we didn't cause any double puncture and all the saline is going inside the vein, not outside it. This is a quick video. I just need to accelerate it. So this is how we puncture the fistula under ultrasound guidance, and we can see the needle going inside the vein just to be sure that we are in the correct position, and then we inject the saline followed by the thrombolysis. And then, because the early part or the distal part of the fistula, usually it's still open and pulsating, so we'll have some arterial blood flow coming out of the cannula. Then we put the thrombolysis and we inject it with a rate 1 ml per minute. And then after at least 30 minutes and maybe up to 6 hours, we do a transverse incision where the cannula is, and we do thrombectomy, mechanical thrombectomy, using a Fogarty catheter and doing an angiogram to see if there is any underlying disease, which is present in 80% of the cases. And this is the clots we retrieve. The angiogram is important to address the stenosis segment of the axis. If the stenosis segment could be treated surgically in the same session, we do that. Otherwise, we defer the patient to a later date to schedule him for a later angioplasty once the equipment are available. We prescribe all patients to have aspirin 81 milligram and apixaban 2.5 BID for 6 months, and recommended no heparin needed during hemodialysis, but there is no evidence-based medicine about this strategy. This one we do the angiogram and highlight the underlying disease. So far we have enrolled 26 patients using this technique, 16 males, 19 fistula and 7 grafts. Access thrombosis occurred 2 to 14 days before the procedure, an average of 6 days. We have achieved the technical success in 21 patients, which are almost 81%. 6 patients had surgical correction on the same session of a stenotic segment, while 15 patients were scheduled for later angioplasty of the cephalic arch and or central veins. All patients who failed to recanalize their axis had the procedure more than 5 days since the last dialysis session from this axis. 4 of them had aneurysmal dilatation more than 2 centimeters in at least one segment along the AV axis. We have followed up the successful cases, and at 4 weeks they are all still patent and used for dialysis. 8 weeks following the procedure, 18 cases were still patent and 3 cases occluded while they were waiting for their angioplasty to be done. We didn't have any bleeding complication or mortality. Just of note, 6 patients actually who started the thrombolysis less than 48 hours since the thrombosis, they regained the thrill on a spot without doing the thrombectomy. All of them got thrombectomy as well, except one patient who didn't have a thrombectomy because the operator thought that this will be enough, and he got 1 dialysis session, but on the following day it re-occluded again, and then we brought him back. We got another session of thrombolysis followed by thrombectomy, and it's functioning well. So what we have learned at the time equals success. Thrombolysis alone is not enough. Mechanical thrombectomy alone is difficult and usually fails. Aneurysmal dilatation might be a challenge because of maybe of the thrombus load. Our limitation that we have a small number of patients, short duration of follow-up, late referral from the dialysis units, and delayed intervention due to anesthetic risk and patient preparation. But we concluded from this limited number of patients that actually this is a feasible approach. And just for the sake of time, I just want to stress on future plans. We are planning to recruit larger cohort of patients to be able to reach a reliable conclusion with longer follow-up. We have to increase the awareness of end-stage kidney disease patients and hemodialysis staff about the signs of failing AV access to refer them to vascular surgery unit prior to thrombosis. Increase the awareness as well about the importance of prompt referral of thrombosed AV access to vascular surgery units. We are planning to compare this technique to our standard technique, which was the pulse thrombolysis with angioplasty, and we need to study the aneurysmal dilatation over thrombosed AV access to figure out if large aneurysm is an independent risk factor for failure for restoration of AV function, as this might change how we deal with the AV access aneurysms that we believed to be benign in most of cases. And at the end, we have to tailor our treatment according to the patient and his condition. Thank you very much.